Good morning, everyone, and welcome again to MPHA's annual conference. We are excited to continue the conversation about COVID vaccinations. We're joined by Ann Connors, Director of the Community Health Department at Maine General Medical Center, and we'll be hearing her presentation on equitable vaccine distribution in a pandemic. Before I turn it over to her, just a few announcements that you're likely familiar with. We are offering closed captioning that you can find beneath the video within the session. If you don't need it, you can hit pause. We also, once again, ask you to please take the evaluation via the feedback button in the upper right-hand corner of your screen. And if you have any questions for Ann about her presentation, we will be taking those when she's done. So please use the Q&A feature to ask those. But Ann, I will turn it over to you. Thanks for being with us.
Thank you, Heather, for that introduction. And I wanted to thank MPHA for a really wonderful conference. I miss seeing everybody in person, and I really look forward to being able to hopefully do that next year. But this has been just a great event, and the platform's been wonderful. And all of the presentations have really shifted my thinking in really profound ways. It's just a really rich conference this year. So I wanted to thank you for that. So I'm Ann Connors. I'm the Director of Community Health at Maine General Medical Center. And I wanted to talk to you today about equitable vaccine distribution in a pandemic. And I thank everybody for taking time out of their busy schedules to join me here today. I have nothing to disclose with regard to any commercial relationships. And by the end of the session today, I hope that you'll be able to describe a couple of engagement strategies for vulnerable populations that you can kind of evaluate our equity efforts during this pandemic and consider what the application may be to the environment you're in, and that you could name a couple of barriers to equitable vaccine access. So just to provide some context, this is a picture of the National Guard at the Augusta Civic Center, where we conducted a mass community clinic. We could not have done these clinics without the support of the Guard. It was really critical to us. And we operated our community clinics at the Civic Center from approximately mid-February to July 1st, 2021. Prior to the mid-February move to the Civic Center, we were having community clinics at the hospital, the Alphonse Center for Health. However, it quickly became clear that we needed to be in a bigger venue to meet the needs of our community. And we shut down our operations at the Civic Center on the 1st of July, and we had several second dose clinics that took place back at the hospital. So we kind of came full circle. We started at the hospital, we ended up back there. During this time, we provided 45,946 doses of vaccine, and so that's doses, not people. That's the actual shots in the arms. And an analysis we did after the mass clinic had ended, so retrospectively, not while the clinic was happening, which is one of the challenges of this work at this time, which I'll talk about a little more later. We learned that we had a total of 23,591 unique individuals who attended the COVID clinic at least once. And of that number, the vast majority had a Maine address, or 23,519. So who came to our clinics? And, things have changed so fast. Some days I am, just struggling to keep up. And it's hard to remember sometimes. At the beginning of the pandemic, eligibility for vaccine was determined by age, and the age kept coming down. So we started off with our older populations because they were most at risk, and worked our way down. So what this histogram shows you, the clinic is the orange peachy color, and Kennebec County is green, and Maine is blue. So the clinic attendees skewed older compared to the vaccine eligible population of Kennebec County. So specifically, the clinic was overrepresented for people who were 55 to 59. So the group, I don't know if you can see my cursor, but kind of here on up, and underrepresented for all age categories that were 55 and below. So where were people from? We wanted to serve people in our community, and on that measure alone, we succeeded. Our people who were vaccinated were highly concentrated in Kennebec County, accounting for nearly 78% of all people who got vaccinated. And the largest cluster of attendees resided in Waterville, Augusta, and Gardner metro areas. And then we had smaller clusters in Oakland, Winthrop, Lewiston, Auburn, Topsom, Brunswick, Bath, and Portland. And again, if you remember in the early days of the pandemic, people were driving, some people, not all people, but some people would drive wherever they could get a vaccine to get that vaccine. So who were the people who are coming to our clinic? So the real conclusion is that, we largely mirrored the people we have in Kennebec County. You can see in terms of gender, the proportion female is just about exactly, who came to our clinic, just about exactly the proportion female we have in Kennebec County. In terms of race and ethnicity, again, this is, even though these numbers look like there's a bit of a gap here, it's a bit misleading. It's probably about the same in terms of the percentage of white people we have in Kennebec County and the percentage of white people who are vaccinated at the clinic. So Kennebec County is 97.5% white, and people who came to the clinic were 94.9% white. And I wish I could say that's because we vaccinated more people of color, but it's most likely because in the data, there's a significant number of what comes through in the analysis as non-respondents, which means that people either didn't check their race, or when it was entered, when the data was entered, there was a error and the race was not captured. And this was, again, kind of a problem throughout the pandemic. So we also tried to look in our retrospective analysis at some of the social determinants of health factors, because we all know that education and income really impact not only our access to healthcare, but our health outcomes as well. So clinic attendees came from areas that had less educational attainment than the rest of Kennebec County, but also less poverty. So this is kind of really, one of those things I'm kind of like, what do we do with this? I'm not quite sure, but that was our finding. So less educational attainment, but also less poverty, the people who came to the clinic. So, I wish I could say like, well, so we did this mass clinic and, we're done and it was all great. But that's right. That's not the place that we're at, or nor should it be the place where we're at. So, the COVID-19 pandemic really laid bare the fault lines that already exist in our society, but they were just so much more visible during the pandemic. So we had healthcare disparities in terms of access, difference in social determinants of health. We had cultural mistrust that historically negatively affects minority communities and their access to equitable healthcare. And when we look at who was disproportionately affected, it is people who are Black, Hispanic, Latino, and people who live in rural communities. So our engagement strategies to try to reach the most people as we could is to have the clinic at a central location with public transportation access, and that was the Augusta Civic Center. And I should say, I meant to say it with the slide on the National Guard, that we operated this clinic in partnership with the state of Maine that really provided us with a lot of support all along the way. So the Civic Center was well known to people in the community. Public transportation went there. There was plenty of parking. We did, especially in the early days of vaccination, have a lot of issues in terms of the people coming in to be vaccinated had mobility issues. And so we were able to address that. The state of Maine provided wheelchairs for us. Maine General provided wheelchairs. We had community volunteers who would push people through the vaccination area and the whole process, check-in registration, waiting for the vaccine, the observation area, and then to the parking lot area. And the National Guard also assisted us with transportation. We had, in terms of access around language and people who are hearing impaired, we had a Stratus device. That's a device that Maine General uses in its clinical settings. So it's a tablet that's on it's kind of like a little, I kept thinking of ET because it's about the size of ET and it kind of is a little wobbly. So the tablet's on the top of this little pole, and I am not a techie person, and this was extremely easy to use. Push a couple buttons, and I would say always within 20 seconds, you would have a interpreter on the other end. That was a real person and a real face and voice, and we would wheel that through the clinic using volunteers or the National Guard. We really worked hard to develop very accessible messaging for people. So the right literacy level, not a high barrier in terms of understanding, and using like trusted community members to reach the target audience we were trying to work with. And then we drew upon a collaboration with existing network of strong community partners. And I think it's really important to think about having that existing network, because in the midst of an emergency state, it is not the time to be forming your community partnerships for the first time. To be effective and really have both parties, the healthcare system and the community partners, be able to be bringing the most they each can to the table, there needs to have been a collaboration in place, prior to whatever the event is. And we were fortunate in the community health department to have a long history of having strong community partnerships. And I think also, just honestly, during this process, we saw some areas where we didn't have such strong community partnerships, and we needed, to improve that. And we are taking that kind of very much to heart moving forward. So in terms of access to the clinic, and again, at this phase, I'm talking about the early days when, you remember you had to be navigating websites or calling repeatedly, and it was really hard to get an appointment to get the vaccine. So we knew intuitively that some people were getting left out of this process, right? Because, you had to have a certain level of access, a computer, a phone, persistence, patience, the bandwidth to keep trying to get your appointment. So we developed an outreach program with the goal of decreasing barriers, increasing access, vaccinating everybody in our communities. And we relied on our trusted community partners, so Spectrum Generations, which we have worked with for many years in our healthy living and evidence-based classes, in partnership. Our Horizon Clinic, which is a Maine General primary care clinic for people who are diagnosed and living with HIV, and Kennebec Behavioral Health, which is a mental health agency in our area. So we worked with these three entities. So our approach here was basically, you have the people that need access. We have the vaccine, we have the vaccinators, we have the location. So let's bring both of our strengths and get this done. So what we did is we reserved blocks of clinic time for the clients, people being served by these community-based organizations. And then the community-based organization conducted outreach to the people they were working with. They got back to us with a list of names and the essential demographic info we needed. And we then put these individuals into the scheduling system for their appointment and communicated that back to the community-based organization. So the person wasn't having to navigate that whole system alone. And then, the community-based organization would accompany clients to the clinic, providing, support for social emotional needs, perhaps providing transportation. We're in the process actually of evaluating that experience right now, and trying to, kind of do a retrospective analysis of how that worked for the people being served and for the community-based organizations, and where we can kind of go from there. So in this pilot of outreach, 105 people received appointments, 97 completed their shots, and 8.2% of those who completed their shots were from communities with low vaccination rates. 1% were Black, 65% white or other, 2.1% Native American or Pacific Islander, and 20.6% were unknown. I just have a real big caution about the race data there, in that many did not report their race, and we did not, therefore we couldn't track that. So there's a big caution with that data at this point. And then as we move through the pandemic, the scheduling of appointments changed from one where you had to go through Maine General, just like you would if you were scheduling colonoscopy or a mammogram, to one where we partnered with the state on their online platform called Schedulo, where people could, the public, anybody could go in and book their own appointment. And so that and also access was easing at this point. There was more vaccine available. And so we made sure that our partners knew about the website and how to navigate it. And they worked directly with their clients to get them those appointments. And we did not track that data. So the clinic did close as demand decreased and as vaccine became more available in other settings. So what happened after the clinic closed? And actually it was sort of at one point in July, these efforts were kind of happening simultaneously. So we were wrapping up those second dose clinics and we were starting our pop-up clinics. So our pop-up clinics, we started by looking at rural communities that had low vaccination rates. And we just started calling, them, municipalities, fire departments, police departments, community organizations we knew of in those communities to see if they'd be interested in hosting a clinic. We had the support of the Kennebec County Emergency Management Agency. In this photo in the background is the trailer that's the Kennebec County Emergency Management Agency trailer. And their motto was, you call, we haul. So we like that. And they also partnered with us in terms of, in some of these, very small communities with low vaccination rates, they have, I don't know what the official term is, but, the signs that have the blinking messages that you see for like Maine DOT has them on the side of the road. So they had that sign and they would put it up a week ahead of our clinic in these communities saying, free vaccination, no appointment needed, and the date and the time. So we tried to do outreach that way. We developed flyers for each of our pop-up clinics, and we would go into the communities and put them up wherever we could, bulletin boards at the post office or any community organization that would give them out for us. We found that, hyper local, like one community that we had a lot of people come to, it was because one of the team members who was flyering was her husband. I don't know. There was a family connection in that town, and everybody's like, "Oh, you're here. You guys are doing this," And so we had a lot of people who came, and it was because people knew this one person who was out flyering. So really having that hyper local connection is really helpful. So all told. Oh, and just the locations. We went to town halls, fire departments, local stores, transfer stations. We did I think our first pop-up was at a transfer station. We ended up holding 34 clinics and administering 329 doses through this process. And it was really interesting what we learned about the people who were coming to the pop-ups. And it wasn't that, they had been adamantly anti-vax, and they suddenly got convinced or saw the light. It was people who, they just hadn't been able to get around to it. Maybe they don't have paid time off work. They've been thinking about it, but it just hadn't been able to be a priority in their life for whatever reason. But the fact that we were right there at the transfer station, they're like, well, I guess I'll do it now. So that was a really interesting finding, as well as the hyperlocal finding. We did go to the Windsor Fair. This photo is at the fair, and on the right is Alex Wright, who is the program manager for our COVID clinics, and on the left is Tom Foster, who's the president of the Windsor Fair Association. And we were there for 6 days, all 6 days of the fair, from noon till 6 or 7 o'clock. And having that, constant, steady presence, people saw us there day after day, and would eventually, some people came on the last day and got vaccinated. And the fair was very supportive of having us there, and also offered a free pass to the fair for anybody who got their vaccine shot. We also worked with New Mainers of the Capital area and had 2 clinics at their location. So in the environment where people were accustomed to going and felt safe and comfortable. I will say that this process to administer those 329 doses was very labor intensive, and I'm not sure how sustainable. And I think about some conversations we need to have in public health, after action reports, kind of, once everybody can breathe a little, or through the pandemic a little more, is, how do we sustain this work? Because looking back and, trying to apply a critical lens to our own efforts, it's, I wish we had started these pop-ups sooner in the pandemic process. I also know that starting them sooner would have really strained our capacity. So, who owns this? Who's responsible for this? How do we make these efforts sustainable? Because I think just by virtue of the pop-up clinics being in some of these rural communities with low vaccination rates, that was an education in and of itself, just us being there. I think it was critically important that we did it, but the sustainability of it is something that, I've really been thinking about it. And the future, this framework is from the CDC's journal, Preventing Chronic Disease, Research, Practice, and Policy. And they did an article recently on a framework for mobilizing healthcare to respond to communities within the COVID pandemic. And they suggested that, this is what we need. This framework is what we need to have in place kind of all the time. And if we have this in place all the time, when there is a pandemic or an emergent need, we can easily draw upon like all of the strengths that are in these different buckets. So our community partners, which I've talked about a bit, our healthcare system collaborators, our community leaders, and our academic collaborators. And I feel like in the work that we did, we had pretty much all of these buckets working together, with the exception of perhaps, the academic collaborators. We didn't really have a strong, or had no relationship there. And so that's something to kind of think about going forward. So what's next for us is, right now we're having our flu clinics in schools right now are happening. And then in November and December, we're looking at scheduling COVID clinics in school, anticipating that the Pfizer vaccine will be approved for the 5 to 11-year-old age group. And again, kind of one of our key, we've been doing flu clinics for many years now at Maine General. We have that trusted relationship with the schools. So why would we have COVID in the schools? Well, for one reason, it's where the kids are. For another reason, it is about access. And some parents may not have the capacity to take their kid during the day to get a shot, but they can sign a form to have the kid get a shot at school. So once the FDA advisory committee meets on the 26th and ACIP follows, we'll be able to go ahead and schedule those clinics. So that is the end of my presentation. I'm happy to try to answer any questions you may have or just hear any comments people have.
Thank you, Anne, so much for that great presentation. You all are doing fabulous work and really getting into the community. So thank you for that. We do have some questions coming in. And just as a reminder, please use the Q&A if you have some for Anne. You talked about the sustainability of this work. And one of the questions that came in is, in order to staff all of this, did you have to divert staff from their original jobs? And if so, how did you manage that transition and continue to address and not let their original work fall off?
Well, that's a really good question. And we actually had to hire a lot of staff for this process. There's a online scheduling platform called When to Work, and that we use to schedule our community clinics. And at one point we had almost 400 people in that When to Work. And if you had told me at the beginning of the pandemic that I'd be looking, overseeing 400 people at a community clinic, I would have said that's ridiculous. It's not going to take that many people. But it really did take that many people. And a lot of those, I'm sorry, I don't have the exact number in front of me, but we had like 200 or 150 volunteers. We had a lot of community volunteers who came forward to help us. And getting vaccinators, we started off approaching our retired Maine General RNs, and that was how we started. And then we expanded beyond that, and we also used some existing RNs who, had the capacity to take, a couple shifts a week. As far as the outreach work, those were all people that were brought in for the community clinic operations, and then we kept them on to do this outreach for the pop-up clinic. So that's how we staffed that. And this is all paid for through the FEMA emergency designation, which expires at the end of December. So, just the sustainability thing, I think a couple of other people this morning have also mentioned that is really key to me. And this work is so critical. And as I said, I wish we'd started the pop-up sooner, because I think the right answer, there's a lot of things we don't know yet, or we're not sure about. And I think we need to be kind of humble about that. But, one right thing I think we know is that it should be no wrong door, right? People should be, like the testing presentation prior, people should be able to easily access this in areas where they feel safe with people they know. But how do we sustain that? I don't have an answer.
Thank you. And I think that's on a lot of people's mind is the sustainability. And, one of the reasons why we themed our conference Rebuilding and Moving Forward is to start these dialogues and hopefully continue them after. We had another question come in. Someone keeps hearing a refrain recently that if you haven't been vaccinated by now, you won't agree to be vaccinated. But from your presentation and the one prior, those imply that it's just work going through trusted community organizations and people and a lot of sustained work that we can get more vaccinated. They ask, is this kind of work going on in the communities in Maine with lower vaccination rates? And what do we need to do to make this happen? So it touches a little bit about your sustainability and moving forward, but how do we get those people who aren't vaccinated yet, especially as funds are running out?
Yeah, I do. I really, it's so interesting because it's kind of against the conventional wisdom, right? Because you think, I can understand why people would think if you're not vaccinated yet, you're never going to get vaccinated. And I really don't think that's true. I think that's true of some people. I think there are some people who, are just adamantly opposed and they're not going to change their mind, for sure. But that's not true of everybody. And that's not what we saw in the communities we were in. It was just people who we're public health people. It's a huge priority to us. They had a lot of other stuff going on in their lives. It wasn't, they recognized the importance or they wouldn't have gotten it, but it wasn't something that they could go out of their way to do. But we were right there and they said, hey, okay, well, we'll do it. So yeah, I think, oh, I know what I was going to say. The ideal design for I'm very proud of what we did in the pop-ups. Don't get me wrong. And the team did an amazing job. It was a lot of work and it was really important. And the ideal design would have been if we could have had, because the questioner was saying like, how do we get those people that they're not adamantly opposed, but they just need a little whatever. So what we really wanted to do is to have like an educational outreach by a trusted community person. And a lot of times that's the physician in the community. If there's a longtime physician in the community that's been serving, the kids, and the kids grow up and they serves their kids, to have some kind of information sharing session or ask your questions about the vaccine and then have the vaccine available right there. Like, okay, what do you think? You want to get the shot now? And I think that would be a really wonderful way to go about it. And just in all honesty, the scheduling the ones we scheduled was such a process because, there's the first dose and the second dose. You'd make some phone calls, you'd book somebody in, they'd call back and they'd want the date. And then some other town had taken that date. So it took a long time just to get the bare bones done of what we got done. And I think ideally, like, having that person in the community and having that opportunity for a conversation in a setting where people feel comfortable would be the best way to go.
Thank you. And I think you point out so much of what we all know for those of us who work in public health, that it's long, sustained, dedicated work, but we can do this. So thanks for ending on that note. And we are unfortunately at time. So I want to thank you, Anne, for being with us this morning. Remind people to take the evaluation. And we will be back here at 11 to hear about growing organizational capacity, strengthening our ethnic community-based organizations during COVID-19. So thank you, everybody, and we will see you in just a few more minutes.